Good afternoon, everyone, and thank you for joining us. This is Paige Hancock, Marketing Manager at Spok, and I'll be moderating today's webinar. Today, we'll be talking about improving the patient experience and HCAHPS scores with technology. Rob Wilder, Senior Product Manager at Spok, will share initiatives that your organization can undertake on behalf of patients and the role that technology plays in the patient experience. Before we get started, I would like to go over just a few housekeeping items. Everyone will be muted during today's webinar, but we welcome your participation. Please submit your questions via the questions box, which is in your GoToWebinar toolbar, and then Rob will answer as many questions as time allows after the presentation. A recording of this webinar and the presentation slides will be sent to all registrants tomorrow, and please feel free to share these with your colleagues and others at your organization. And then lastly, at the end of the webinar, you'll have the opportunity to complete a short evaluation. We would love it if you could take a couple of minutes to complete this survey. Your feedback really helps our efforts to provide you with relevant and informative presentations. And with that, I'd like to turn it over to Rob, who will begin our presentation.
Thank you very much. So, as we said, we're going to talk about HCAHPS scores today, and I wanted to cover what they were first, just to get things started. So, whether due to competition in the community or simply the general practice of the organization, hospitals have been tracking patient satisfaction for years. It has gained momentum and focus, especially in the last decade, because now there are very direct financial incentives behind those scores. Back in 2002, the Centers for Medicare Medicaid Services partnered with the Agency for Healthcare Research and Quality to develop the HCAHPS scores and a survey to go along with them. They created this to propose a publicly reported standardized survey, really allowing an apples-to-apples comparison between facilities and for consumers. Today, these surveys, along with other key measurables, are driving decisions of patients on where they look for health care when they're going to look for it. There are also financial incentives for facilities in the IPPS program, or Inpatient Prospective Payment System, since HCAHPS scores are now used in calculating payments for the hospital value-based purchasing program. So patients can receive exceptionally high quality care, yet still be dissatisfied, largely because of their interaction with the providers or how they perceive the staff are communicating with them or not. Patient satisfaction is really a broad topic and can include everything from concierge service and upscale meals to bedside haircuts. Today we're going to focus primarily on communication, and I'll start with the question, why does patient satisfaction matter? Of the hospital-related questions on the HCAHPS survey, 2 specifically ask about staff responsiveness to calls for assistance, and approximately 10 are related to communications in general. So the challenge here is to manage constant stream of patient requests efficiently to the correct care provider without driving overload that leads to fatigue. Ensuring requests are directed to the correct roles and with the proper level of importance for prioritization is also key. For example, a request for pain medication would be routed to the nurse, while perhaps a nursing tech could bring a glass of water or assist a patient in walking around the floor. And routing of these events to the right person is important. For respiratory or other distresses, a rapid response team might need to be the appropriate notification path. Routing these kinds of events correctly ensures that immediate notifications can be delivered while maintaining efficiency and staff satisfaction. So along with these notifications comes noise, typically. There's a multitude of audible disturbances from multiple sources in the hospital environment. Overhead paging on the unit for general notifications or code calls happen throughout the day. Patient care devices beeping or alarming in the room can lead to problems for both the patient and the staff that support them. Phones ringing loudly at stations or on wireless phones, which the staff would be carrying around them, especially when the staff are with the patient. This becomes a bigger problem. Hallway conversations and hallway noise in general, like squeaky carts, are another example of these. All of these contribute to a louder environment, with the majority of them that you see here being rooted in methods of communication. So what are the effects when all of these sounds are present? The effects of sound on our environment can be more damaging than we realize. And this is exacerbated in a healthcare environment where healing is a primary goal. So alarms in the ICU and in the OR frequently lead to sound levels up to 70 decibels. These levels correspond to the sound of heavy traffic in our daily lives. And if you live in a quiet neighborhood and you're used to sleeping in a quiet neighborhood, and then you go on travel and you have trouble sleeping in a hotel that might be next to a highway, this is a pretty similar effect. For patients, an undisturbed night's sleep, sound levels below 40 decibels are recommended. Sound levels on the ICU can be frequently above this level from device alarms or overhead pages, and this makes sleep deprivation in the ICU patients a common problem, which can lead to some more serious issues we'll cover next. We should not forget also about staff and the effects of noise on them as well. Studies have shown there's a proven relationship between increased sound levels in the ICU and nurse burnout. Now let's look at the negative effects of sound on our patients when these sounds go unaddressed. Sleep deprivation and arousal from sleep are common problems, and repetitive arousal from sleep can lead to issues beyond just the patient's satisfaction. Sleep deprivation in the ICU patients has been proven to lead to an impairment of the immune response and increased sympathetic nervous system activity as well. Frequent arousal from sleep may lead to cardiac arrhythmias in patients, not only for those with pre-existing heart disease, but also in healthy patients. We all have seen the news on increasing opioid problems in the US, and studies have shown that significantly increased opioid needs are present when noise levels are high because patients are being woken up constantly. Patients in a high noise environment also have been shown in studies to consistently have higher rates of rehospitalization, which is a target for performance with many facilities. Some technology and isolated systems have come out to help with these issues of noise, but these technologies can help, and they can't help really when they're not used. Furthermore, bad or incorrectly deployed technology only adds complexity and makes matters worse instead of improving things. A couple of good examples I like to share when it comes to these is my personal experience walking around facilities, noticing that facilities have the patient care devices, for instance, plugged into wall panels or contact closures on the wall, whether provided by an older nurse call system or a contact closure vendor. These systems can provide notifications, but they inevitably lead to fatigue because they're sending out everything without a filter. And many of those notifications go out with very rudimentary notifications that really don't provide the right amount of content to know what this type of event is. And the result of that we've seen from walking around these facilities is cords laying on the floor. Hospitals have the practice to plug these into the wall, but inevitably the nurses pull them out of the wall because they're notifying them way too often, and they're not able to tell what's real versus what's not. With that present, we go right back to where we started, and we have noises in the room that are going off, alarms that are going off that need to be addressed, that could potentially be causing problems for the patient and without notification to the nurse. A good example of that, another facility example that we've seen out there is an environment where we have nursing walking around with good devices. They have good phones, but they're using them primarily for voice communications, and there's no notification structure for the devices. Sitting in a room, something I observed, sitting in a room with a patient and them having an end of infusion on the infusion pump, that noise starts to go off and it annoys not only the patient but the family members as well. And notification from the patient by the nurse call system is kind of rudimentary, and you still have to wait for the nurse to come. So automated notifications of these allow us to address the alarms much, much quicker. So let's look at some examples of proper use of communications technology with modern practices that help diminish or eliminate these issues. So we wanted to talk about quiet time, and many of you may know about quiet time because it's been around for a little while, and there's many facilities looking to deploy it today if they haven't already. Quiet time has been a target initiative since articles on the subject were produced around 2009, and hospitals have been implementing it since 2014, roughly, with innovators starting the adoption followed by others. The need for these practices was driven by many of the factors we discussed here today, and some common approaches have been identified by organizations that have implemented it so far. So some of the key places to start, based on history and based on documentation from multiple sources, is to start small, focusing on simple interventions aimed at changing existing systems and advanced staff awareness of quiet time. And when we say staff awareness, we're thinking about everybody that might be involved in the facility above and beyond just the clinicians. Interview on approach with clinicians. Collaboration is really critically important. And each unit is going to need to have an approach on noise a little bit differently. Including non-clinical roles. As we said, operational staff are constantly on the floor as well. They are communicating, they're talking, they're rolling around carts. They need to understand the mission and feel like they're part of that effort. So inclusion of all of the roles within the hospital is important. So how can communications help work to support these quiet time efforts? There are ways Spok can help with quiet time. First, having a smart device is really important. With an ever-increasing need for mobility in the healthcare workforce, our phones are now becoming our desktops. Devices can carry the need to be able to provide the content staff need for immediate understanding and efficient response to events, and clear voice communications as well, to make sure that they can be efficient when they're on the phone or talk quietly. These devices also need the ability to notify uniquely with adjustable volume, vibrate capabilities, and assignable ringtones for any priority level. If we can hear what types of events are coming at us, we can respond to them more quickly, or we can silence them more easily or have them come in more quietly. Having an efficient and secure way of texting silently with individuals or groups can diminish the need for phone calls, especially in patient-sensitive areas where we might have problems with noise. Implementation of time delays is also an important addition. A great number of false alarms are caused by only mid-threshold violations or of short duration, and the implementation of a delay for notifications can reduce alarms by up to 70%. And if we're not receiving notifications on alarms, we're diminishing the noise that's generated on any one of the units that we're deploying that on. The implementation of a graduated delay, less delay over time, can bring an additional safety or flexibility to this approach. In this environment, severe conditions can be addressed immediately, while less critical scenarios can be delayed based on the type of event they represent. Automated event timers can be implemented as well with quiet time to change the way notifications are delivered for non-critical notifications, like from an audible tone to a vibrate after a particular hour. We can diminish noise while still getting the word out for important tasks or general messaging. And for an example, this would be water requests coming from the nurse call system going out to phones, or let's say lower level patient care device alarms compared to a code call, which would really need to be something that goes out and everybody knows about, or a fire alarm. Diminishing the noise on non-critical tasks will allow us to keep doing our jobs without having to disturb the patients to do them. So we've seen the results of quiet time initiatives through research with individual sites, and also through organizations such as ECRI or World Health Organization. Some of these numbers are very telling from the initiatives that have been deployed. Up to 80% increase in HCAHPS scores for some facilities. Reduction of overhead paging needs by up to 98%. A virtual elimination of overhead paging in many of these facilities. Delays for non-critical notifications can reduce false alarms by up to 70%. And as we said, less notifications means less noise and a more efficient staff. Streamlining communications with secure and efficient quiet text or voice conversations. And maintaining World Health Organization requirements for community noise with an ambitious target of noise levels lower than 30 decibels in patient environments. These results are driven by a combination of best practices for staff and the technology to support them. Spok's been a provider of this technology for years, and we're always looking for ways to improve the environment for patients and staff we support in healthcare. That's the end of our presentation, and I can open up the floor for questions.
Excellent. Thank you, Rob, so much for that insightful presentation. We will take some time now for audience questions. It looks like we have a couple that were submitted already, but just a reminder that if you do have a question, please submit it in the questions box in your toolbar, and then we will answer as many as time allows. So Rob, our first question is, what types of roles would you suggest that we include in planning a quiet time initiative?
Okay, so really that's everybody within the organization. So naturally starting with the clinical roles, but expanding that into anywhere from your dietary services, your security folks, really anybody that walks the floor, and identifying those people early on to bring them into the effort, or at least leadership from each one of those departments to help promote quiet time is really important. Excellent,
thanks. Another attendee has asked, can you share your sources for the industry stats that you mentioned?
Yes, and many of them will be included in the presentation that we send out. For the problem study information, the U.S. National Library of Medicine and the National Institute of Health were referenced. The Center for Medicare Medicaid, of course, we mentioned earlier in the presentation. ECRI Institute, we like to work with them, and we look for information from them as we can get it. And there were multiple unlisted blogs and industry articles that we reviewed just to make sure that some of the information here was consistent. From a results perspective, we got a lot of information from Modern Healthcare and also from the World Health Organization site itself based on historical findings they had.
All right, thanks, Rob. I'm just checking to see if we have any more questions that came in here. It looks like that is the end of our questions today, so we'll be sure to follow up with you if you had a comment or anything that we can take offline. If you'd like to chat with a Spok representative on the topics that we discussed today, you can do so using the link in the chat box. And you can also continue the conversation with fellow attendees by using the hashtag SpokWebinar on Twitter. Follow us on Twitter, LinkedIn, and Facebook to get all of the latest news from Spok, as well as industry news and trends. Thank you all for joining us. We hope that you found this webinar informative and that you have a great day.